also. Now I request Dr. KVV Satyanarayana sir to deliver his talk on perspective of angle closure glaucoma.
Good morning. Sorry. Good morning to the chairpersons and my friends. Today my talk on perspective of the angle closure glaucoma. So no financial interest. So PACD is a dangerous variant of glaucoma. So primary angle closure disease that includes about the primary angle closure suspect, primary angle closure and primary angle closure glaucoma along with the acute angle closure glaucoma. These clinical findings are shallow AC with raised IOP because of the pupillary block or arteriotrabecular contact with leads to the ultimate blindness if it's not treated in time. Paul Foster in 8th World Glaucoma Congress cautioned that Asia harbors the highest percentage of primary angle closure disease. So prevalence of this PACD is becoming on the rise because of the increased number of centenarians, because of the increasing life expectancy, because of the improved health facilities. So incidence of angle closure glaucoma in Asia is 40 times higher than among the Caucasians. We have to think about this point. And the prevalence of PACD is also rise in the West. West, they are supposed to think that POAC is more common in the West, but recent trends in the last 10 decades, in the decade that they are telling that PACD is on the rise in the West also. This is the incidence of acute angle closure glaucoma in emergency department of the US, and PACD is more common in the West now, including UK and Italy. When it comes to the Indian scenario, the PACD incidence is almost 50-50 in some parts of the north and including the PGI, West Bengal study and the Shankar Nethralaya. But prevalence of glaucoma in the North Coastal Andhra, we have conducted a study from Regional Eye Hospital of Visakhapatnam. Our conclusions are POAC is 43.6% and PACD is 24% around. And there is a disproportionate burden of blindness because of the PACD. And PACD blindness is 3 times higher than the open angle glaucoma. And blindness in the India because of the PACD is on the rise. About it harbors about 1.5 million blind people are in India are blind because of the glaucoma, mostly because of the angle closure suspects. And there is one paper recently from RP Center stating that the rapidly emerging non-communicable ocular disease in India because of the glaucoma blindness. And when it comes to the pathology, mechanism, that the Curran, who is the father of angle closure glaucoma, proposed this relative pupillary block theory in 1920 itself. And later the World Glaucoma Association proposed some other mechanisms of the ciliary body, lens, causes behind the posterior segment and lens also. So we can predict by simple tests to pick up the angle closure glaucomas by seeing the pattern of the iris. Less number of furrows, it is an indication of angle closure suspect. And also when the iris dilates, there should be a disproportionate loss of the iris volume. This equation will be lost in angle closure glaucoma. And PACD is more common in Chinese. Why it's more common in Chinese? Because most of the studies says that anterior insertion of the iris is more common in the Chinese, and also thick peripheral iris. And the Chinese iris is more sticky. It's more prone for the angle closure diseases and the PSC formation. And if you look into the retinal arterioles, angle closure glaucoma has the narrowest angle closure when compared to the open angle glaucoma. And the decay of the RNFL is more rapid and acute in angle closure glaucoma when compared to the open angle glaucoma. So there is a classification Frost in 2000 by ISJO, classified into PACS, PAC and PACG, which is useful for the diagnosis and management point of view. And there is another classification, pre-glaucoma and glaucoma stage, where it includes the acute stage of glaucoma in open angle and glaucoma stage. And progression, it leads to 73% of chronic PACs are without any symptoms. This is the most stressor point we have to think it of. Acute angle closure glaucoma, as you know, the family history plays a most significant role. These are all the risk factors, but genetic predisposition is most common. age is the definite risk factor both for the open angle glaucoma as well as the narrow angle glaucoma. And the lens thickness is a major risk factor. As the age advances, the thickness also of the lens is also increased. Myopia is not an exemption. Where we have to stress more at this point, there are studies shows that about 2 to 11% of the cases of myopes, they are having the angle closure attacks. So ethnicity, especially the Japan, they are more prone for two types of glaucomas, angle closure as well as the normal tension glaucoma. And this angle closure glaucoma is more proportionate and more in the low socio-economic group. And as you say that glaucoma is the pattern of investigation, start with a simple torchlight flashlight test. And as Dr. G.V. Reddy says, the gonioscopy is mandatory. I stress more upon the gonioscopy. Do gonioscopy, repeat on the second day, third day, till you confident about the angle configuration. So gonioscopy is mandatory, which shows these narrow angles, occludable angles, closed angles, as well as with peripheral antisynechia. So some cases, chronic headaches, they are being treated with the neurophysicians thinking that it is a case of migraine. But after 10 years, this cases has been referred to the ophthalmologist. By doing the simple gonioscopic examination, they labeled it as a primary angle closure glaucoma. This is already late. And there are automatic this thing as management, as you all know, that laser peripheral iridotomy, it reduces the incidence of angle closure glaucoma in the west as well as in the east. Eagle study shows the clear lens extraction, deepens the anterior chamber, and don't neglect the fellow eye. This is because 40 to 80% of these cases are prone for that. And awareness, creating awareness regarding the angle closure glaucoma is a must. Take home message, PACs, these are the roads for the blindness, permanent blindness. Simple 5 minutes examination of the salvashi with gonioscopic that can prevent the permanent blindness. Female, don't neglect a female of 50 years with hyperopia. Think about the incidence of PACD. Don't ignore the family history. Flashlight test. You don't need any sophisticated instruments. If you have the thing in mind, that simple flashlight examination, you can pick up a shallow AC. Gonioscopy is mandatory, and LPA, simple treatment, is very effective, can prevent from the blindness. Don't wait for the symptoms to develop, because symptoms rarely, 75%, they don't have any symptoms. And put pilocarpine if LPA laser facilities are not available. Incomplete PA is very dangerous because it produces aseptic uveitis. It leads to peripheral antisynechia. Finally, it lands up in the PACG. And regular follow-up in spite of patent PA is also essential. PACG blindness is avoidable if you pick up this case at an early stage. Thank you.
Thank you so much, sir, Satyanarayana sir, for giving a nice talk. Somehow I missed one point in the slide. POEG is called as a giant and PSEG is called as a, something you have mentioned in the slides. Sir, POEG as a giant and PSEG as a, you have mentioned somewhere as POEG is a giant and PSEG is a?
PS is a big giant more than the POEG.
Giant. I thought it will be zombie. Okay, thank you so much, sir.